Good morning, everyone, and welcome to our broadcast. I'm Lisa McGovern, and I serve as Executive Director of the Prevent Cancer Foundation's Congressional Families Cancer Prevention Program. Let me begin today by thanking our panelists and our hosts here at the National Association of Broadcasters studio. And thanks as well to you for joining us today and watching from your homes, offices, and mobile devices as we explore the alarming increasing incidences of colorectal cancer in young adults under the age of 50. Most of us think of colorectal cancer as something that happens to older people, and perhaps that's why, when symptoms occur, they are often mistaken for something else, not only by the patient, but often even by the doctor. We've convened today's panel to help us better understand both this disturbing new trend and this disease. In addition to our two highly esteemed experts, Dr. John Marshall and Dr. Kimmie, we will hear from Pat Beauregard, a 31-year-old patient, advocate, Marine, husband, and the nephew of a dear friend of mine. He is generously sharing his story to help others, and we are so grateful to you, Pat, for traveling from Massachusetts with Dr. Ng to be with us here today. We will also hear about Prevent Cancer Foundation's edgy new campaign to raise awareness among young adults. Now, before you meet our panel, let me say a few words about the Congressional Families Cancer Prevention Program, for those of you who may not know us. We are a bipartisan group of spouses to members of the United States Congress, both the House of Representatives and the Senate, and we are committed to educating ourselves and the public to help save lives across all populations through cancer prevention and early detection. In a time when we hear too little about bipartisanship, I am proud to tell you that this program began in 1991 as a partnership between the Prevent Cancer Foundation and the Congressional Club, and we have been growing stronger with each year, building bridges across the aisle, working together to help build a healthier America. We would not be able to do this important education and outreach without our program sponsors who support our efforts throughout the year. So, in addition to thanking the National Association of Broadcasters for hosting us today, we thank you for your annual support. I also want to recognize two other very special program sponsors, Bristol Myers Squibb and Hologic. You make this work possible, and we are very grateful to have such loyal corporate partners. I also want to thank Cassie Smith, who works with me at the Congressional Families Program, for making all of this work so smoothly. Thank you, Cassie. So now let's get started. To help us frame and moderate this discussion, I would like to turn the program over to Dr. John Marshall, Chief of the Division of Hematology and Oncology at Georgetown University Hospital. Dr. Marshall received his training at Duke University, the University of Louisville, and Georgetown University. He is an internationally recognized expert in new drug development for GI cancer, and with expertise in phase 1, 2, and 3 trial design. Dr. Marshall has become an outspoken advocate for GI cancer patients and the importance of clinical research participation. In 2009, he established the Otto J. Ruesch Center for the Cure of GI Cancer, an organization solely focused on improving the lives of GI cancer patients through innovative research, personalized medicine, and focused advocacy. So as you can see, he's a very busy man, and we are fortunate that he is able to be with us today to moderate our panel. Thank you, Dr. Marshall, and welcome.
Lisa, thank you very, very much. And really, I want to thank our panel for being here today and joining us all in Washington, D.C., making the trip down. And a particular thank you to the Congressional Families Cancer Prevention Program for inviting me to moderate this really important discussion. So let me set the stage here a bit. So colorectal cancer is the third most commonly diagnosed cancer in men and women in the United States. It is also a global health problem. As Lisa mentioned, although many people associate it with older folks, so people like me, there's been a striking change in recent years of the number of young people who are diagnosed with this cancer. When I first signed up for this job now a long time ago, there was nobody in my clinic under the age of 50. If there was somebody, it was somebody with an inherited cancer syndrome. And now I have to say, although Washington is a young town, almost half of my clinic is under the age of 50. And when I am confronted with this question, the answer is I don't know why this is happening. I don't know what's going on. There was a lot of push to say that this was people who were not exercising or eating wrong, or those, and it turns out that almost everybody that I see under the age of 50 are, as I sort of joke, are marathon running, cardboard eating people. So they're doing all the right things, and yet here they are getting colorectal cancer. And that's really why we're here today, is to learn more about this important issue, hear what our medical experts and cancer advocates are doing about it, and what young adults need to know, and how you can help spread the awareness from your end as you learn about this today. Now, I'm going to start to introduce our amazing panel. So without further ado, let's give them the baton. So let me start by this incredible doc who is right next to me, Dr. Kimmie Ng, who's a physician and an associate professor of medicine at the Harvard Medical School. She's the director of clinical and biospecimen, that's what that word is, research in the Center of Gastrointestinal Oncology at the Dana-Farber Cancer Institute. Just an amazing place full of amazing people, and she is indeed one of those leaders. And she's now the founding director of the Dana-Farber's Young Onset Colorectal Cancer Center. Her research is really spans many different areas, but it's around identifying dietary and molecular and genetic predictors for cancer and cancer patterns in colorectal cancer. Dr. Ng also co-leads the Colorectal Cancer Working Group and the Gastrointestinal Committee, which is a national group called the Alliance for Clinical Trials in Oncology, and this big cooperative group all across the country. So she's leading the charge for our group as a GI group to change the world. And this is a National Cancer Institute program. She's the recipient of numerous grants. She's very prolific in both her research and her patient care, and her real goal is to do that, is to change the world for colorectal cancer patients. So welcome, Dr. Ng. Next to her is Patrick Beauregard, an intelligence specialist in the Marine Corps. Pat was diagnosed with stage 4 colon cancer in September of 2017 at the age of 29, shortly after returning from his honeymoon. He's now a patient of Dr. Ng's and draws from his own experience to be an advocate for colorectal cancer awareness in younger adults. Patrick, welcome.
Thank you, Dr. Marshall.
Glad to have you. And finally, last but not least, next to Pat is Lisa Barry-Edwards, who's the Managing Director of External Affairs at the Prevent Cancer Foundation. She's here to talk a bit about the foundation's campaign to really raise awareness around colorectal cancer. As you said, edgy in younger adults. If you're going to be edgy, let's do it. It's called Too Young for This Shit. Lisa, welcome. All right, with that, I'm going to hand the baton to Dr. Ng, who's going to give us a lot more detail about this growing issue and what the new center she's working on is doing about it. Dr. Ng.
Thank you so much, Dr. Marshall, and thank you for having me here. This is a wonderful opportunity to educate and raise awareness about this rising burden of colorectal cancer in young adults. So as you said, Dr. Marshall, we have noticed in our clinic that more and more patients are young, under the age of 50, with none of the traditional risk factors that we typically associate with colorectal cancer, including family history, a genetic syndrome, inflammatory bowel disease. And we really have no idea why this was happening. And so as a response to this conundrum, we established the Dana-Farber Young Onset Colorectal Cancer Center to rally around the clinical care of these patients, which can often be challenging and unique, and also to rally all the brightest minds around a research effort dedicated to understanding why this is happening. So with that, the issue first got pushed into the media spotlight, I would say, with Rebecca Siegel's paper published in the Journal of the National Cancer Institute that showed that colon cancer rates are rising in individuals under the age of 50 years old. This graph is a little bit hard to read, but basically each of them represents a certain age group. So the first one is ages 20 to 29, the second is people age 30 to 39, and the third graph at the top there in the red box is people ages 40 to 49. The rest are 50 to 54, and then in increments of 5 years after that. The x-axis is the year, and so as you can see, in individuals under the age of 50, the incidence of colon cancer has been steadily rising in the range of 1 to 3% per year since 1980. For the rest of the age groups, especially for those who are getting screened regularly with colonoscopies and other tests, the incidence has been steadily decreasing for the older population. The same trends are seen for rectal cancer, where rectal cancer rates are rising actually even more steeply among the young population, particularly in the group between the ages of 30 and 39, which is represented by the second graph in the red box. In addition, young patients are diagnosed with more advanced disease. 41% waited over 6 months before seeking medical attention for their symptoms because colon cancer is not on the radar of young people when they do have symptoms. Over 40% had to see more than one physician, 2 or more, sometimes 3, before arriving at the correct diagnosis. Again, because colon cancer is also not on the radar of the medical community who are at the front lines of seeing patients with these symptoms. And this leads to 71% of young onset colon cancer patients being diagnosed with stage 3 or 4 disease, which is much less curable than if you catch these early at stage 1 or 2. This all prompted the American Cancer Society to lower the recommended screening age for colon cancer from 50 to age 45. It is unclear if this is currently being routinely implemented, but it is a first right step in the right direction. Now, although it's difficult to receive a diagnosis of cancer no matter what age you are, we do know that young patients face unique challenges when they are facing a diagnosis like this. In a survey of young onset colorectal cancer patients conducted by the Colon Cancer Alliance, 85% reported depression and anxiety around this diagnosis. 80% have children under the age of 18 when they are diagnosed. And 64% of them reported that they were not spoken to about fertility or recommended for fertility counseling at the time of their diagnosis and prior to starting treatment. 64% reported interrupting school or their jobs in order to face this diagnosis and treatment, and that leads to 62% reporting financial difficulties around the fact that they now have to deal with a life-threatening illness. So around all of these very important issues, Dana-Farber decided to launch the Young Onset Colorectal Cancer Center in March of this year. There's a threefold mission inherent in the center. One is focused on clinical care, providing expert, compassionate, and cutting-edge care to patients with young onset colorectal cancer, and that's defined as receiving a diagnosis under the age of 50. The second mission is research, to promote scientific discovery and innovation so that we can understand the underlying biological mechanisms, identify the risk factors, and come up with novel ways to treat this disease in young people. And finally, raising education and awareness, both for patients and the larger community as well as the medical community, about this rising burden of colorectal cancer in young people and advocating for new ways to prevent and detect this cancer earlier. So to go into a little bit more depth about each of our missions, in terms of clinical care, just like everybody who comes to Dana-Farber Cancer Institute, everyone will receive a multidisciplinary evaluation. But what's unique about the patients coming to our center is that we will now expedite an upfront genetics appointment. We do know that discovering a hereditary predisposition or genetic syndrome is slightly more common when you're diagnosed younger. And so this is a very important part of the workup and care of patients with young onset colorectal cancer. The next underpinning of our center is personalized treatment, where every young onset patient will have their tumors sequenced with our in-house OncoPanel next generation sequencing platform. Having a genomic profile of the patient's tumor will then allow this to be reviewed by a molecular tumor board as part of our program called GI Target, which is for treatment assistance, reporting genomic evaluations of tumors program. So as part of this GI Target program, every report is analyzed by a molecular tumor board, and then a personalized treatment recommendation of clinical trial options or other out-of-the-box treatment options that are tailored specifically to that patient will be returned to the oncologist. And we know now that this approach of a tailored medicine is much more effective than the kitchen sink approach of throwing chemotherapy at everybody that walks through the door. The other part of our clinical care is having a dedicated program coordinator assigned to every young onset colorectal cancer patient that comes to our clinic. And we know that it can often be difficult to navigate the complex health systems of a large cancer institute. So having someone act as a liaison to the clinical and research teams, as well as oversee expedited referrals to all the supportive services that patients need to get through their cancer journey, is of critical importance. And finally, related to that, having a dedicated social worker as well to provide one-on-one support as well as programming so that patients can meet other young patients suffering through this disease and learn other tips and tools for navigating the experience is also a critical part of our new center. In regards to research, we are forming a new prospective cohort study of young onset colorectal cancer patients called Beyond CRC. And this stands for Better Understanding of Young Onset Colorectal Cancer. We chose the name because there are so many ways to live beyond a colon cancer diagnosis. One way to get around it is to complete your treatment, of course, and then go through surveillance. Another is to learn how to cope with treatment and living with the cancer while receiving treatment. Another way is supportive care, not just for the medical diagnosis of colon cancer, but for the whole patient, and not just for the patient, but for their whole family. And finally, another way to live beyond colorectal cancer is to help those who come after by participating in research. So this is a new prospective longitudinal cohort study of young onset colorectal cancer patients where we will collect clinical, treatment, and survival data. We will collect biospecimens to include tumor, blood, and stool samples, as well as comprehensive diet and lifestyle information from all of these patients. We hope to bring the best and brightest minds together from all disciplines of research, laboratory, epidemiologic, translational, and clinical, to look at various aspects of young onset colorectal tumors, including differences in genetic variants, gene expression, protein expression. We want to characterize the immune microenvironment and study the microbiome, and we want to look at dietary and lifestyle factors as well. And then finally, the third mission is to increase public awareness and education. So for patients, we will be holding regular seminars, webinars, and an annual forum, providing regular newsletters with updates about general information about colon cancer as well as new research in the field, and partnering with foundations and patient advocates to raise awareness. And then for the medical community at large, Dana-Farber's Colon Rectal Cancer Center produces regular podcasts, and there will be a series around young onset colorectal cancer coming out soon. We'll be presenting at medical and research conferences and summits, as well as reaching out to our referral base in the community in regards to primary care practices, gastroenterology practices, as well as community cancer centers. And finally, having a multimedia presence will also raise awareness of this rising issue. If you want more information about our center, we are on the web, danafarber.org/youngcrc, and our email address is there as well. I would like to now pass the baton to Pat Beauregard, my amazing patient. I think the issue is not more clearly expressed than if it's coming from the perspective of a patient. So here.
Thank you very much. Thank you for this opportunity and allowing me to share my story. So I can certainly relate to a lot of what Dr. Ng and Dr. Marshall already touched on, although I think my story is unique in a couple different ways. So again, as previously stated, I was diagnosed stage 4 colon cancer at the age of 29 back in September of 2017. Just a month prior, I had just gotten married. I went away on a honeymoon. I came back to work, and I was back to work for about a week or two, and a normal everyday work day ended, and I had severe stomach pains, something that I had never really experienced before. These were very lasting and severe stomach pains. So I tried to tough it out. I toughed it out through the night, and the next day the pains were not subsiding at all. So that's when I finally decided to check myself into the emergency room in Boston where I live. And at that point, again, they ran certain tests. I couldn't get anything down. I was vomiting. I couldn't get any fluids down. But again, cancer at that point was the last thing on my mind, and actually the last thing on their mind as well. When I was in the emergency room, I was almost, I'd say, a split second away from getting sent home with some constipation relief treatment, and they were going to send me on my way. However, again, those pains were not subsiding at all, so they finally just said, you know what, well, let's just run a CT scan of my abdomen just in case, and that is when they noticed the tumor. And at that point, it seemed I was still very optimistic at first because it seemed like the tumor was very contained to my colon, so they thought that I would maybe be diagnosed stage 1 or stage 2. However, afterwards, they did run a CT of my chest, and that's when they noticed what seemed to be metastases into my lungs, and that's when I was diagnosed stage 4. So yeah, again, it was very sudden and very shocking for me. I don't think that I had exhibited any symptoms prior to my diagnosis, although again, when you're young and you're healthy and you're kind of going through life like that, colorectal cancer is kind of the last thing, or any type of cancer really, is the last thing on your mind at that point. And again, when I was in the hospital afterwards, they asked me if I had exhibited certain symptoms, or if I had felt certain things, and to be honest, I answered no to pretty much every question. I thought I was taking care of my body. Again, I was preparing for a wedding, so I was working out a lot. So I thought I was in great shape. I thought there's no way that I have this cancer inside my body, and I don't know about it. Unfortunately, that I was diagnosed again stage 4, and then I sought out multiple opinions, and thankfully I ended up with Dr. Ng at Dana-Farber, and the treatment I've received has been amazing from not only Dr. Ng, but the entire staff there. So since that time, I did undergo a surgery to remove the primary tumor from my colon, and since then I've been battling to fight those metastases to my lungs and some lymph nodes. I've currently undergone 33 rounds of chemotherapy, and just last week I started a brand new clinical trial through Dana-Farber, so I'm very much looking forward to continuing that. So, thank you very much.
Patrick, that's just an amazing story, one that we're tired of hearing, quite honestly, in our world. I mean, I don't want to put you on the spot, but as you were telling your story, I'd love to hear when that doc came in to tell you that they thought they had colon cancer. What was their face like? What were they surprised? What was the reaction of the healthcare team when you were first finding out about this?
Very much so. I'd say they definitely were surprised. And again, I was completely surprised, shocked, in denial, I think, at first. Again, I hadn't, as far as I could tell, I hadn't presented any symptoms previously to those severe stomach pains just out of the blue one day. And again, they asked me if I had experienced any shortness of breath, blood in my stool. Yeah. Again, I answered no to all those questions. I think one of the issues with colorectal cancer is some of the symptoms are very generalized. So if you have, if you're having stomach pains, cramping, of course, everyone's kind of experienced that before, I think, in their lives. But you do, again, colorectal cancer is kind of the furthest thing from your mind at that point. When you're so young and you think you're healthy, you kind of dismiss it. So I've said before, it's possible that I may have exhibited some symptoms before those stomach pains, but I could have just brushed them off and thought that they were just, maybe I ate something bad that day, or, it was just one of those days, and that was it. Yeah.
I mean, Dr. Ng, that's sort of what that research you were showing, is that we're not ready for that diagnosis as physicians. And so lots of people have ate a bad taco, and lots of people have what is called inflammatory bowel disease, or stuff like that. And we're sort of this huge gap in our own awareness.
And that's just the problem, because overall colon cancer in young people is still relatively rare, and there are more common things that could explain some of these symptoms that are so common. And so how do you know when to act on something and work up something when the likelihood is still relatively low on an absolute scale, but we do know the incidence is rising?
Yeah, we're going to come back to this very important topic of how we spread the word and educate each other. But so thank you, Patrick and Dr. Ng. But we now really want to turn to Lisa Berry Edwards, who's going to tell us about the Prevent Cancer Foundation's new campaign, Too Young for This Shit. I'm really looking forward to your description and maybe a little bit of behind the scenes deciding to name it this and how it's going so far. So
absolutely.
Take it away.
Thank you so much. And I just want to thank Dr. Ng and Pat for their remarks. I think what you said really illustrates the need for this campaign and why we developed it in the first place. What we were hearing was that, colorectal cancer is rising in younger adults and people aren't aware. The patients aren't aware, the doctors aren't aware. So we decided at the Prevent Cancer Foundation it was time to really do something about this. But it's hard to break through that idea that colorectal cancer isn't something you need to worry about until you're older. And quite frankly, people think they're too young for this shit. So that's where the idea came from. And we came up with Too Young for This Shit to be a little edgy, a little unconventional, but it captures your attention.
Do you have an emoji? That's what I want.
We don't have an emoji. Actually, there were a lot of discussions about using those poop emojis, but they're trademarked, so you gotta look out for that. What we do have are some great visuals. I'll pull one up here. And our goal with these images is really to tell people that, number one, there's preventive steps that we all should be taking to reduce your risk of colorectal cancer. Number two, there are signs and symptoms that you need to be aware of so that if you're experiencing something, you can really advocate for yourself and talk to your doctor and go get a second opinion. And number three, that if you are age 45 or older, you really should be getting screened. And Dr. Ng mentioned the American Cancer Society changed that screening guideline for those at average risk from 50 to 45. A lot of people don't know about that still, so we want people of that age to know. So we're hoping that, being a little out there will catch some attention, it'll get people talking, and it'll get the message out about colorectal cancer increasing for those under the age of 50.
So this is a group, just right back, that's not used to going to doctors. I mean, young men particularly don't really go to their primary care doctor regularly. Women, I think, do more for healthy checks, GYN kinds of things. But, so that's, to me, part of this issue. Do you think the campaign can help close that gap around young people and awareness?
I hope that it will. We did a soft launch this March, so we're still kind of waiting to see what the results are. And we have big plans for how we're going to continue to expand the campaign and really get the word out. So then we'll see. But we made sure, we wanted to use representation in the campaign. We had both men and women pictured. We had people of different ethnicities so that people would really see themselves represented and know that this message applies to them.
Yeah, so much of our materials that we have for patients is old gray-haired folks on the cover, and so you don't really identify at all with the younger folks. I think that'll be very helpful.
And you asked, I'm sorry, you asked about behind the scenes, so
Yeah.
I'll just give you a quick, really behind the scenes. Being a nonprofit, we don't have a lot of funding for these things, so our models were actually all volunteers, some Prevent Cancer Foundation staff, some friends and family members, so they really went to bat to get this word out. We were in a staff member's apartment, really kind of a low budget photo shoot, but it was all people who are actually in the age range that we're talking to about this message.
You roped your own husband into this.
I did.
Took one for the team.
That is terrific. Dr. Ng, you were talking about the sort of public health nature of it, and part of our role is to educate those docs in emergency rooms and in urgent care centers and primary care and the like. But you brought up the point that I think is so important, that we as healthcare providers have to make really difficult judgment calls all day, every day. Do we send everybody for a colonoscopy and a CAT scan? Is that just, or should we try to treat it symptomatically because the majority of those things are going to go away? So I'm always respectful and forgiving of our primary care frontline docs who are having to make these decisions. Can you talk a little bit about that from your perspective?
Right, and I don't know that I have the answer for you about this because, as you said, there are many more common things that can explain so many of the different symptoms. I would say, and what I've been talking to my primary care colleagues about and folks in the emergency room and urgent cares is that if a symptom that could potentially be concerning for colorectal cancer doesn't go away, if it's persistent or if it's associated with red flags like unexplained weight loss, for instance, those are the kinds of things that should not be dismissed just purely based on somebody's age, at being too young for this to be a possibility. And I think that just having the awareness that colon cancer should be on the differential, at least, when you are encountering and having a patient sit in front of you who has these symptoms, that's an important first step in even trying to catch these at an earlier stage.
But so often we see, it's a we'll hear the story on the other end. The 30-year-old woman, let's say, has had a couple of kids, maybe has some hemorrhoids, has some bleeding, and as a physician, do you put a 30-year-old through a colonoscopy when you've got a pretty good reason for the symptoms. But if it was a 60-year-old woman with hemorrhoids who had some bleeding, I think that patient would be sent right away for some sort of colorectal cancer screening. So
that's exactly right. I think you have to look at the whole rest of the patient as well. Is there a family history? Are there perhaps dietary and lifestyle factors that we know increase the risk of colon cancer overall?
Most people aren't having those, right?
Correct.
They're coming in squeaky clean.
Correct. And so I think this points to the need for more research. How do we identify the people who are young and who really do need to be sent for screening? I have talked to several of my primary care colleagues, and they now have the opinion that if somebody presents with bleeding in the stool or any symptom concerning, that they will actually refer for further workup because they are aware of this rising incidence.
Well, let's go a little bit further on the research question. I've been thinking a lot to myself that if those curves you showed, and this is a little bit biting, but those curves you showed had been breast cancer incidence rising in younger people, that I actually think we would have, not only some dedicated, 18-day march to raise money for it, but there would be, congressional funding, and we would do everything we could, an all-out war to figure out why that's happening. And yet, at least from my end, I'm not seeing, we're having to do grassroots education to raise awareness around this. So talk to me a little bit, because you're so good in this space, about the research that's going on in this area and what you're doing in particular, and maybe take a chance to reflect a bit on what should we be doing and how should we be approaching this.
So studying what the risk factors are for young onset colorectal cancer has been challenging because we don't have contemporary cohorts of people organized formally in research studies where they were exposed to the environmental factors that we think are leading to this rise. We don't have that established, and that's part of the impetus for us establishing the Beyond Colorectal Cancer Project, is to get these people together and to partner with patients to try to understand this.
So simply measuring what's going on, right?
Right, and then the databases that we do have may not be comprehensive enough. So are there stool samples for us to look at microbiome? Are there comprehensive dietary and lifestyle questionnaires where we can assess what people have been doing starting in early life leading up to the time of their diagnosis? And then are there blood and tumor specimens as well, and clinical and treatment and survival information, all in one database and with enough numbers of young onset colorectal cancer patients for us to have statistical power to be able to make any conclusions that will lead us to better understand the mechanism. So we are trying to rally around this to do it. And so, we have access to one cohort right now, the Nurses Health Study 2, which is a longitudinal prospective cohort housed at Harvard that enrolled female nurses ages 25 to 42 starting in 1989. Right. And we follow them every 2 years with dietary and lifestyle questionnaires and have diet updated every 4 years. And these are completely healthy people. And then we follow them for a variety of different health outcomes, including colon cancer. And using that cohort, we now have 2 studies that show we're starting with studying the traditional risk factors associated with colon cancer overall. So one looked at obesity, and we did find that being overweight or being obese did seem to increase your risk of developing colon cancer at a young age.
Obese.
I'm not saying it explains the whole story, because it definitely doesn't, and there's so much that we don't know. And you're absolutely right. He is the opposite of that.
He's the opposite of that.
And then the other study was looking at sedentary behavior. Again, he is the opposite of that. But we did find that people who sat down and watched TV 1 to 2 hours a day or more had a significantly increased risk of developing colon cancer.
Those are some of the things that we've traditionally thought about. And as I've been stewing on this, what is in your environment or our environment now that might be changing this? Because we rule out sort of what we know about family history, and because we know the genetics on that. We talk about this microbiome. I want to drill down a little bit on that with you. If it's our cell phones or Starbucks coffee, we're not going to be giving that up. I think we're just going to accept the increased cancer and go on. Or
Dunkin' Donuts.
Or Dunkin' Donuts, yeah. So to be equal. There we go. Sorry, of course. I'm hoping on some level that this immersion of what I think of as an epidemic of young people will actually teach us some new fundamental lesson about cancer in general, the cancer biology. But do you have a leading thought on environmental factors that might be contributing? You talked about obesity and sort of being sedentary. Is there, everybody's talking about what we're eating, what's in our air. What thoughts on that?
Right, so it's interesting that the rise in young onset colon cancer has paralleled the rise in obesity. It's paralleled the rise in vitamin D deficiency in the United States. It's also paralleled the rise in processed foods. And so our hypotheses do center around these diet and lifestyle factors. And I actually think that they may be interacting through the microbiome, which is the community of microorganisms that live in our gut and that outnumber human cells in our body. They may be interacting to affect the microbiome, which affects inflammation in the body and the immune composition of our body, which could very well contribute to the development of colon cancer as well as how we respond to colon cancer treatments. And so part of our research effort is to try to characterize the immune environment and the inflammatory environment around young onset tumors compared to older onset tumors to see if there are any differences that will lead to new ways to treat.
Yeah, I mean, when I went to medical school, there were still books. There were books back then, but there was no discussion of microbiome. It was something we, in fact, washed away so that we would get to the human side of the formula, and yet we've evolved over millions of years to retain these bacteria as part of our health. And so some of the work that we're doing here at Georgetown is really focused on understanding the microbiome and its role that it might play in colorectal cancer. Patrick, let me kind of skip to you for a second. So after having a diagnosis of cancer, it's very common for patients to sort of reflect back and say, I wish I had, or I wish I hadn't done something. Was there something on your list that you sort of reflected back and blamed on this?
I wish I almost had something like that, Dr. Marshall, because unfortunately for me, again, I think the most frustrating thing throughout this journey for me is not knowing what caused this. And I'm so glad to hear of the Early Onset Colorectal Cancer Center at Dana-Farber and the campaign Too Young for This Shit. And I think you do need it to be edgy because, again, when I was first diagnosed, I hadn't even really heard of colorectal cancer. And yet you said, Dr. Marshall, it's the third most commonly diagnosed cancer. If it was, I agree that I think if it was something like breast cancer, people would be up in arms, but you don't really hear about it nearly as much. So I guess people maybe think that it's not as prevalent, it's not as big of a deal. So I'm just so glad to hear about the work and raising awareness. I think it's absolutely critical.
We all know about the pink ribbons, so the colon cancer ribbons are blue, but I've always advocated they should be brown. I think we should just go with the brown ribbon and do that. We can maybe think about that as the second phase of the campaign.
And if I may, I mean, breast cancer was not always so out there with the awareness and the advocacy for it. It was a very hush-hush cancer diagnosis. And I think colorectal cancer is maybe still there.
Let me step in, and this is where government and our political figures take a lead. It's really Betty Ford who starts the breast cancer movement when she gets breast cancer in the White House, while she's in the White House, and pushed it to the point that there was now Department of Defense funding for breast cancer awareness and research. So
I do think that is a place where the Congressional Families Cancer Prevention Program, congressional spouses have some increased visibility, and members of Congress to try to get this on people's radars in a new way. And with the Prevent Cancer Foundation campaign, that speaks directly to the audience that we're trying to capture. So it's a little strange for somebody my age and with teenage children, 17-year-old, 21-year-old, I'm trying to get them not to say shit, but they do, and that's what they will respond to. So so we did have that internal discussion, but we are trying to figure out ways. How do we get people to pay attention here? Because there is so much to talk about. There's so much content out there, but this is really important. So that's how this was born.
Yeah, you brought this up about it not being. I could go to a cocktail party, we could go to cocktail parties and talk about breast cancer. That's now okay, when it wasn't. It didn't used to be that way. And now we are seeing, due to these kinds of efforts, where people will come up and talk about this at a cocktail party, and that's where it really needs to be.
And just sharing your story, Pat, I mean, that is such an important step because it gets people talking about it and kind of erases that stigma.
Well, and it's funny because when I told some of the people that work in the cancer community, and especially the gastro cancer community, about this campaign, one of the people said to me, you know what, I've been saying this for a long time, that we need to talk about shit. I mean, we need to say, we need to, because it does get people to focus sort of on really what, what are the symptoms that we need to be looking out for, and how can we talk about this, and how can we, like as you suggest with breast cancer, take it out of the closet and have honest conversations, like how can we make this more okay and more common knowledge. So it's an airing of both the disease, the trend, and the symptoms.
And the reason I'm so hopeful about the microbiome stories is not just cancer, probably. It's our immune system, all these peanut allergies, all the other things that are coming forward. We're learning more. So it's that shit's turning into a very important part of our health.
Right.
And studying it in a way that we can move things forward. And as scientists, we've been taking apart the human DNA bit by bit, and we're running out of things to find there, at least my nervousness is. And so this gives us an entire new area for research. And every day I'm seeing some new publication around this sort of area. So fingers crossed.
I also want to point out that not only is the incidence rising in young onset colorectal cancer, but mortality. So death from colon cancer is rising. And we don't know exactly why. I do think that being diagnosed at a later stage contributes to that. And so all the efforts to raise awareness about prevention and increase adherence to screening will certainly help with trying to catch this at an earlier stage. But we also think that these cancers might be biologically more aggressive. There are maybe some differences that are starting to emerge, that these cancers have molecular, unique features molecularly. And so trying to figure out what those are and can we come up with a targeted or personalized treatment for young onset colorectal cancer is also really important.
Yeah, just to piggyback on that, is we've just finally figured out that, as crazy as that might be, is that right-sided colon cancers are different than left-sided colon cancers. And now we have young versus old. And so we're seeing different trends, and it's not all one cancer. It's a bunch of different cancers.
That's right.
So let's talk a little bit about screening and the current recommendations. You mentioned this, the increase to 45. It was always 45 for African Americans, now extended for everybody to 45. And my feelings on this is I'm all for screening. I'm positive for more people having access to prevention and screening. But to me, it doesn't solve the problem. It doesn't solve that young man's problem right there. And so maybe let's talk first what the basics for screening are, and then we can talk a little bit about how to deal with the younger folks.
Yeah, so the American Cancer Society recommended for somebody at average risk, so no family history, no history of polyps, no inflammatory bowel disease, that the age be lowered from 50 down to 45. And it was a cost-benefit analysis in part, where this was thought to be resulted in a favorable balance of life years saved and not too much of an increased burden of actually performing colonoscopies. But the important thing about these guidelines is that they don't specify that it has to be a colonoscopy.
Right.
So it can be a stool-based test. It can be a structural exam that may be not the full colonoscopy, but a shorter flexible sigmoidoscopy. But that the important thing is to give patients a choice, and that it's more important to actually do screening than to completely opt out.
Yeah, I mean, we're the only country, I think I'm right in this, where colonoscopy is the standard of care, the gold standard, where most other countries do the stool-based testing.
Still doing stool cards, exactly.
And we're seeing ads for the little box, I think it's Cologuard has a little ad now running around on major television, so maybe this will help. But even with all of that screening, again, let's compare to, say, mammography, where I think the uptake on that is very, very high. The majority of women are getting those tests. I think we're not doing quite so well in colorectal cancer.
So overall right now, there's only about a 60% adherence rate to screening for people age 50 and older.
And that's at any time, any one test, right?
That's any test at all. So we are far from being where we want to be. And this isn't a very effective method to pick up cancers earlier, to prevent cancer, and we're still only 60% of people doing it. So there are active campaigns going around the country to increase and improve adherence to these guidelines, but we are still a long ways off.
Why do you think that is? Why do you think it is?
So I think that people are hesitant to do colonoscopies. They're worried about the need to take off from work, to undergo anesthesia, to do the bowel prep, which is a big thing. And it is true that there are complications. They're rare, but there are potential complications from doing the screening. And then stool-based test is also a bit inconvenient. I mean, you can do it at home. It's less invasive, but it's still somewhat inconvenient. And so another part of it is I think people may not be aware that this could be an issue. So again, raising awareness that colon cancer is the third most common cause of cancer in the United States is very important. And so there are systems being put together, navigators to help people really follow through. The other problem, I think, is that if you do a stool-based test, that has to be followed up with a colonoscopy if it's abnormal. And that adherence to the follow-up test that will actually remove the polyp or diagnose the cancer may not always be happening.
Are there any concerns about over-testing?
There are, and especially in this younger population where other conditions might be more common as a reason for blood in the stool or abdominal pain, there are reasons. And so is a colonoscopy necessary for those under the age of 50? I'm not sure. Most of them are left-sided. They're distal colon or rectum. Those cancers tend to, so is a stool-based test, for example, something to start with for the young population? I don't know. And I agree with you, though, that starting at age 45 does not solve the problem. There are so many 30-year-olds, 20-year-olds who are coming in with this, and they're not going to be caught.
Yeah, it's very helpful, though. We have to reassure.
This is going to be really in the weeds, but this is a question I really want to ask. When we talk about blood in the stools, would it be obvious? I mean, would it be obvious to anyone, or would you see it on your toilet paper? I mean, I'm getting graphic here, but just for people watching that, are sort of like, I mean, would I know it if I saw it, or I saw that? Like, is that something I should be worried about? Like, because things can get dark down there. So, so what, I mean, will people know it if they see it? Is it?
No.
Okay.
And so it can often be microscopic and occult, and so you do need these special tests that have special chemicals or other substances that can develop microscopic hemoglobin in the stool, because a lot of it, especially if it's from the right colon, is not necessarily visible, and it can lead to anemia, low blood counts in your blood without you ever seeing blood in the stool, without you ever knowing. So
red blood on the paper, red blood in the water is almost always not cancer. I mean, there are some that can do that, but usually it is what we call occult. You don't see it.
So would there be other things like anemia? Like if you were at the doctor's office, then that might be something that would be a flag, obviously.
And that's ongoing blood loss, right? To get anemic, you have to have lost enough blood for your iron stores to go down. So usually that's been around a while. And our whole screening strategy is to apply some test to the population as a whole to try and identify cancers. And part of what we're learning here is that colon cancer is not one disease. So colonoscopy can pick up some cancers. It probably doesn't pick them all up. It's fundamentally based on the fact that it comes from a polyp, and a polyp can take 5 to 15 years to become cancer. And so this interval of colonoscopy every now and then is based on that kind of biology. Well, we're learning that there's more than one kind of colon cancer, not all of them starting as polyps. So this is where the stool test advocates are coming through and saying that's a more frequent test, and you're looking at broader types. There are plenty of breast cancers that are not detected by mammogram, right? So we've escalated those to MRIs and other tests. And I think for us to just say colonoscopy is the only test for one kind of cancer, it is, and it's being successful. Your graph showing the over 50 doing better. And I think that's because that's that kind of colon cancer. And what we're trading it for is maybe some new kinds that maybe colonoscopy isn't the most effective, but helpful.
But I think these questions illustrate for me the real need for preventive measures and healthy behaviors, because those are behaviors you need to implement when you're in your 20s and your 30s, whether you're concerned about getting colorectal cancer then or after you're 50. If you're smoking, that's a risk factor. If you have a diet high in red meat and processed meats, if you're overweight or obese or not physically active, heavy alcohol use. So we need to address those behaviors and get people to make healthy choices when they're young.
One thing I wanted to piggyback on what you said, Dr. Marshall, is when you're talking about polyps and family history, we may ask our parents, is there any history of cancer in our family, and what is it? Should we be asking, is there any history of polyps? Is that an indicator? Is that something that we want to take or tell our kids if, one of us had a colonoscopy and there was some polyps removed? Like, that's not the level of detail that we're used to thinking about when we have the conversations with our kids or with our parents. Should we be?
So it depends on the kind of polyp, because there are many different kinds.
Oh,
if it's a tubular adenoma, those are the kinds that are on the pathway towards becoming cancer. But even then, not all adenomas become cancer, and so it is an imperfect surrogate endpoint of whether someone is at risk of colon cancer. If you have a polyp, you are at increased risk, but whether or not having a family history of polyps should prompt earlier screening, I don't know that we know the answer to that.
And we're still not really clear about, what's being inherited here. I mean, just because you had it, does it mean it's something about my genetics? Could it have been diet or environmental too? That's a family shares, right? So there's so much we don't know. This is the problem, that about who and why people are getting this disease. That yes, we can optimize and reduce the number of people that get it by the stuff we do know, right? But there's still a huge group of people that's unaccounted for, that we have no idea why that person got colon cancer, that person got colon cancer, and others don't. So this is why this is fabulous that you're hosting this, and that we can at least get awareness out, and we also want to really expand research and collaboration in this field.
Well, thank you guys for the research that you're doing, and like you said, I mean, taking preventive steps may not be a guarantee, but at least it will minimize the risk and put us in the right direction. So it's important to do everything we can within our power, knowing that not everything is within our control.
Well, and I think it's back to your point about participation in screening, or the concern that even with these screening tests, people aren't using them. They're afraid. They're afraid that they don't want this diagnosis. They don't want to look under the bed. They don't want to look under that rock. And it's important. This is one of those where early detection really matters. It's the difference between a very high cure rate and not. And
that speaks to something. I mean, who doesn't want to hear when you go in for a test, everything's okay? I mean, so the idea of advocating for yourself, the idea that you, Pat, went to several doctors. I mean, that takes. I mean, that's part of what we're pushing for with this conversation, is to have people listen to themselves, because you do want to hear the best news, and it's like, thank God, But if your body keeps telling you something different, you need to listen to that, even if you're not really getting the response you want in the doctor's office. Can you talk a little bit about your experience there?
I completely agree. As a young adult, you're gonna have to be, I think, somewhat aggressive and push and be an advocate for your health, because I think there is still that stigma, like you talked about, both on the patient side and I think maybe a lot on the primary care side, where colorectal cancer is just the furthest thing from your mind. So I have heard stories. Friends have reached out to me and said, I've been experiencing some of these symptoms, and I went to, actually one of my friends said he went to his primary care physician and he happened to mention my story, and his doctor was just like, oh, well, he must have a family history of it. That's it. And I think that's kind of the old school way of thinking. And he said, oh, you're young, you're healthy, you work out, there's no way you have colorectal cancer. So again, I think you do need to be a very strong advocate, and if you're getting dismissed by one of your doctors and you're still experiencing these symptoms, you really need to push to either get screened or do whatever to follow up on that.
Can I follow up on a slightly different topic? Can you talk a little bit about the impact of this diagnosis and treatment on your life? Young folks usually have to keep working because of their health care insurance. That's how they get their health care insurance. And yet you have to take every 2 weeks, a day or so off work to come get your treatment. And how has it impacted your life, just the mechanics of your life, of keeping your work going? But also, we've talked a little bit about being a young person and somewhat stigmatized, I would think, with having cancer, being unusual in that. Could you just talk a little bit about that?
So I maintained, and I still have maintained working throughout my diagnosis. It has been tough, definitely. When you hear that news of stage 4 cancer, a lot of your future plans and goals, maybe you put on hold, or you're not sure. I don't want to be morbid, but I mean, that's the reality of it. You're not sure how much time you may or may not have left. So I think that actually this diagnosis has brought a lot of good in my life, and positivity kind of brings you more on the present and focused more here and now. But it is definitely challenging as a young adult, and I think it's a little bit different. I can't speak obviously to being a much older patient, but I know as a younger adult, you want to be as aggressive as possible in trying to cure this in any way you can. I know that's exactly how I felt, because again, I feel like I still have my whole life ahead of me. So I want to do everything I can to beat this.
And your work has been, you still work in the government? Are you still in the military?
No, I no longer in the military.
All right.
Yes.
And so, but work has been supportive of this?
Very much so, yeah. I can't thank my work enough. They've been extremely understanding and given me the time that I need when I was going through endless rounds of chemotherapy every other week. It definitely is very tough, very grueling, but they've been awesome in that.
Well, and cancer therapies are just very expensive too, and so the maintenance of health insurance is critical to you as a young couple and all of that too, right?
Yes, absolutely, Dr. Marshall.
And
Well, I just want to say a word, because on top of all of that, on top of maintaining your marriage, your work, your family stuff, the idea that you not just today have used your voice and taken time to tell your story through, I've seen multiple interviews with you. I know your brother ran the marathon for you. I mean, you've gone above and beyond, which is like so exactly what we are so proud of in our military, that it's service and taking the opportunity not just to get through this yourself, but to help other people. I mean, we're so grateful for that. So thank you. Because your story, the information is important, and people need it, but what makes the impact is when they hear you. So thank you for that.
Oh, thank you.
Lisa, maybe you could kind of get us moving forward and talk a little bit about how you see the campaign going in the future, and maybe a little bit about what we all can do, including our viewers, can do to spread awareness.
Yeah, absolutely. We're hoping to put these images where people are. So we're talking about getting them in bathroom stalls and restaurants and concert venues and where younger adults are at. And then we're also counting on everyone to share these images and really spread the word, because people hear a message more when it comes from one of their peers. So they're all available on tooyoungforthis.org. If you go to the website, you can get the images, you can share them on your social media, you can pass them around to your friends and family. And we're really hoping to enlist people like Pat and friends and family and everyone you know to get that message out.
Dr. Ng, any closing thoughts?
No, I just want to thank you for this opportunity. Having this webcast is going to make a huge impact on increasing awareness and advocacy for young patients getting this disease, and I do think it's going to make a huge impact, so thank you.
Thank you for being here. No, I just want to close out Pat, do you have anything you'd like to close with?
No, thank you again for this opportunity and letting me tell my story. Thank you very much.
Well, and we want to say that Pat's wife is here with us today, Amanda, and we're so grateful that you made the trip down here, both you and Dr. Ng. You flew down on Easter Sunday, and it wasn't the best timing, maybe, but you made it work, and we're really grateful for that. Yeah. Dr. Marshall, some closing thoughts?
No, I think this is very, very important. The research funding needs to go forward. We need to figure out what's going on here. And my hope is that this will be an investment, not just for an emerging group of young folks who are facing a really difficult challenge, but will teach us a lot about our health, a lot about our interactions in our environment, may in fact totally change how we think about screening for everyone if we can figure out this piece of the puzzle. So it's an opportunity for us, and I think the collaborative research and collective research, the participation in clinical trials and the like are critical to our improved understanding. And so just to echo everyone else's thanks for the opportunity to be part of this, and thanks for the chance to sort of share the world that we're living in increasingly, and we don't like it very much, and it's a bunch of shit, right? And so we would really like to make changes as quickly as we can. We're in a hurry.
Well, thank you all. I'm just going to close out here by thanking Lisa, my colleague at the Prevent Cancer Foundation. For those of you who are watching, we'll be sending more information about the campaign and how you can share it. We hope you'll share it broadly and widely throughout social media, and we'll also talk about how we're moving forward. I also want to thank, once again, NAB, the National Association of Broadcasters, and all the spouses out there. Thank you very much.